take it.
Okay, thanks, Neil, very much. Well, it's great to be here, even though it's virtual. And Lou inspired me to go in endocrine. I was just this poor little intern at Berkshire Medical Center, and Lou would bust in and start asking us questions. And he really inspired me to do an endocrine fellowship. But first, I had to do some general medicine. So I went up to Bangor and did general medicine and found myself taking care of endocrine cases. So I called Sweet Lou. So we used to call Lou up, and he'd, immediately have answers that were always right. So then it was time for me to decide that I really want to do an endocrine fellowship. So I talked to Lou, and he said, well, of course, you can come to UMass. But I chose Dartmouth, and he never let me forget it. And he said, why would you go there, Cliff? And I'm not sure at this stage in my life if I can remember what the impetus was to go to Dartmouth. But anyways, so then I came back and started a lab in Bangor and started doing practice. And I'd fly over the state to different towns in the state and do endocrine referrals. And I'd always call Lou up. And then Lou had this idea. He says, Cliff, why don't you come down and you can come to Endocrine Grand Rounds and continue your enrichment down here on Tuesdays from Bangor. And I said, well, that sounds like actually a good idea. It's 2.5 hours away. And at the time, our hospital was trying to join, we were sending cardiac patients to Joe Alpert anyways, and Jim Dallin, who were there as part of UMass in cardiology. So I would drive down on Tuesdays and go to Grand Rounds. And every time I would come and sit there, he'd always make me feel comfortable, except at the end of the talk, Lou would always say, Cliff, don't you see now why you should have gone to UMass for your fellowship? So then Lou went on to become editor at JCNM, and he was gracious enough to let me start reviewing papers. And all told, he really was a tremendous inspiration for me. And in fact, my daughter, who had postpartum thyroiditis with her first child, went to see Lou at BU, and he took care of her just a couple of years ago before he passed away. So it's been a real positive experience for me to think of Lou and remember Sweet Lou and all his stories. The only negative thing was he'd always tell me that when I was divorced and he was trying to fix me up with a Jewish friend, and I didn't go for it. And he would nudge me just like he did with fellowship and say, Cliff, you should have married this woman I wanted to fix you up with. She's Jewish. Typical Lou. All right, I'm going to share my screen and I'm going to get started. So thanks again for inviting me and allowing me to talk a little bit about some of the recent work we've been doing with Bruce Spiegelman and his lab at Dana-Farber, and talk about irisin and its role in regulation of the skeleton during exercise. So let's see if I can advance. Let's see how I can advance. Whoops. There we go. Okay, so I'll go through 4 components. First, I'll do a little bit about what's the evidence that exercise really does have a role in regulating bone mass, because we all assume that it does. And then talk a little bit about what happens acutely during exercise to the skeleton. And those of you who are taking the boards will pay attention to understanding how bone remodeling works normally and how this might have an effect. And then talk a little bit about what irisin is doing in the skeleton from some of our mouse models, and finish with some significant aspects. So everybody prescribes, everybody agrees, sort of, that exercise is good for bones. I mean, it's a natural prescription that we do in our clinic all the time, and nobody would say, gee, exercise isn't good for you. But we don't really understand, unlike other disorders, chronic diseases such as obesity or cardiovascular disease, we really don't appreciate as much what effect exercise has long-term on morbidity and mortality. And indeed, there's an element of skeptics who don't believe that exercise really has much impact on the skeleton. And Gina Collada is one of them from the New York Times. She happens to be somebody I have run with, and I know, and we talk to on a regular basis. And she has challenged me a number of times to come up with good evidence that running at least has a positive effect on bones. So I'm going to show you some data from meta-analyses and then some individual trials, and you can make up your own mind about the skeleton. So this is a really good meta-analysis by age in children from Bonnie Specker at Brookings, South Dakota, in which she collected data on a number of trials of exercise, primarily running, but also jumping, in children at different age groups, from prepubertal to early pubertal and then post-pubertal. And as you can see, there is a positive effect in that early age group. And one of my conclusions from a lot of our studies is that probably during an early phase of bone acquisition, physical loading and exercise probably does have some impact on improving bone mass. And here you can see that the sum of these trials show that there is a positive effect. It's not dramatic, but it certainly is there. Whereas it isn't in older individuals and certainly not in post-pubertal children. And now another meta-analysis was recently published, this again in adults now, all the exercise studies, and you can see that there's a fair amount of heterogeneity, but no real impact on total bone density. If anything, it's relatively small. And then this most recent meta-analysis from Frontiers of Endocrinology, so the number of studies longitudinally get bigger, but the heterogeneity gets even more impressive, and one could argue that the effect is really very, very small on bone mineral density. So it's sort of a wash with exercise in older individuals in terms of bone density. We have virtually no data in fractures. For fracture efficacy, that's a much larger trial that needs to be designed, but really hasn't been done. And so we can use bone density as a surrogate, but it doesn't always predict fractures. This is a study of elderly postmenopausal women, 37, that had an intervention that included resistance training. And here you can see, and these are controlled, those that didn't do it versus those that did. And there is a significant increase in bone density at one time point, but no change in fracture risk. So one of the other areas that we've explored and others have started to explore is whether exercise can prevent weight loss-induced bone loss. So with gastrectomy, vertical sleeve gastrectomy, calorie restriction, any type of weight loss, bone loss occurs. The mechanisms are not really clear-cut, and we've been studying that with the group in Michigan with Orman McDougall, and we're still not clear, at least in animal models, what's driving bone loss during acute weight loss. But the concept has been that maybe exercise could prevent weight loss induced bone loss. And here you see some unpublished data from one of our colleagues, Kristen Beavers at Wake Forest, who's conducting a large trial now of weight loss versus with or without exercise. And what you can see is that really bone density doesn't change much with weight loss in terms of exercise. So in the middle column, you can see that this is weight loss plus a regular aerobic training, and there's no difference. There's a slight difference if we think about it in terms of weight loss plus resistance training, but only for volumetric bone density. The other parameters, including bone strength, are really not different. So exercise per se doesn't look like it attenuates the rate of bone loss. And Dennis Varia did a similar study, a smaller study, and pretty much showed the same thing. Resistance training can help muscle strength, but it really doesn't do much to attenuate the bone loss. It does a little bit, as you'll see in section E of the graph, but there's still consistent bone loss. And again, there's no fracture data. So that's an issue. More recently, there's been a lot of interest in cycling for a lot of reasons, including the virus. You can't find a bicycle anymore. But among long-term cyclists, there's some evidence. This is work from Dan Barry and Wendy Court in Colorado. They've shown a significant reduction in bone mass during long-term cyclists over a 1-year period. And this raised the question of what's going on? Why would bone loss occur in different areas in response to exercise, fairly intense exercise? And so we are interested in understanding why, number one, exercise really doesn't have a huge impact on skeleton. You'd think it would be an anabolic stimulus that would drive bone formation, but it certainly is not evident from the in vivo data, and it's certainly different than what we see in mice, where we do have somewhat of an anabolic response to long-term treadmill training. So during this part of the talk, I'm going to discuss two aspects, markers, CTX, which is a marker of remodeling that is associated with bone resorption. So you have the osteoclasts, which dissolve bone, the osteoblasts that form new bone, and then you have osteocytes that you see down there, those stellar cells, which really are the command and control mechanism for regulating bone remodeling. And our teaching has always been that remodeling is tightly coupled. Formation occurs after resorption begins and bone is reformed. So we can use measurement of CTX for bone resorption, and we can look at sclerostin, which is produced by the osteocyte, as an indirect measure of bone formation. Sclerostin is released by the osteocyte and suppresses new bone formation. So any elevation in sclerostin would suggest that bone is being suppressed in terms of formation. And the worst combination that you would have, and that you see with glucocorticoids and other serious chronic complications in terms of the skeleton, is a high CTX, suggesting high bone resorption, and a high sclerostin, suggesting suppressed bone formation. Okay, so more recently, a number of investigators have been looking at the response to acute exercise, jumping, running, and what's fairly consistent is that sclerostin levels go up during acute exercise within the first 5 to 10 minutes. And this occurs with running, and it occurs with cycling. And this increase is also associated with an increase in CTX with intense exercise. So as you begin this acute exercise intervention, you get signals that are actually catabolic. And that's an interesting concept. Why would the skeleton respond in sort of a negative way to acute bout of loading? And it's loading either cycling or in the case of running, obviously it's gravitary loading. So I think we understand that a little bit better, and I'll come back to it in a minute. So basic training is a great 8-week subacute form of exercise in which people are carrying, 60-pound loads and really working hard. Most of these people are not in shape when they enter an exercise regimen for training purposes. And so they're going to lose weight and at the same time also put a fairly heavy load on their skeleton. And it's disappointing. This is from the Natick Research Center just down the road from you guys, Julie Hughes's data, that there's really a heterogeneous response to this loading. Some individuals show an increase in bone density, but overall, in the N=91, there really was no change in bone mass, despite a few that had hyperresponsive, that is a 2% increase in bone density. But what was really interesting is that in all these individuals, CTX, a marker of bone resorption, was increased significantly. That was the most consistent measure. So if bone resorption is going up, why is it going up during acute exercise? And what's happening to serum calcium? So this is work from Wendy Court at Colorado, who's done the majority of the work in this field of acute exercise and the skeleton. And she is a clinical trialist with beautifully designed studies. So she took women and had them cycle for 60 minutes. These are young, 30, 35-year-old women, no chronic diseases. And what she did is she measured CTX, and she didn't measure sclerostin, but she measured CTX and PTH. And she hypothesized that the increase in bone resorption was a secondary phenomena related to a drop in serum calcium. And she hypothesized initially that that drop in serum calcium within the first 10 minutes of exercise was a recompartmentalization of the calcium. Either it was going somewhere else, it was going in sweat, or it was going out in the urine, or it was going into muscle. And she suspected that the resorption effect was a secondary phenomena due to the body's attempt to compensate for a drop in calcium. So this is the demographic characteristics of the individuals, of healthy individuals, normal vitamin D, normal bone density. And these data are really pretty provocative, because not only did she do it in normal individuals, but she also gave a calcium infusion, suspecting that the drop in calcium was what was driving the increase in bone resorption. So if you look at the saline infusion, which is the clear dots, what she showed was ionized calcium drops dramatically in the first 15 to 20 minutes. And this occurs in total calcium as well, and measured by a number of different measurements. But in the individuals that got a saline infusion at the time that the serum calcium dropped, of course, the total calcium remained the same. So she was able to blunt the effect of the drop in calcium by giving calcium. So she was right that the calcium was going somewhere and was dropping out of the circulation, but she wasn't sure where it was. And with some eloquent studies, she showed it was not in the sweat, it was not in the stool, it was not in the urine, and is likely going into muscle very acutely, although we don't understand that mechanism well. But what's really remarkable about this study, and I continue to, every time I show it, I get so excited about it, is that the serum PTH levels go up rapidly. And this reflects this drop in serum calcium. The body is so good in a homeostatic mechanism that as soon as you get this drop of calcium, the first thing the body's going to do is increase parathyroid hormone to maintain serum calcium. And this indeed is what happens. It's not a complete compensation, because as Wendy showed, the calcium does continue to drop a little bit, although not into the unsafe ranges. But this very acute burst of PTH is almost certainly what's responsible for the increase, the subsequent increase in bone resorption. And we'll come back to the mechanism of that. But that is a very classic physiologic response to a drop in calcium. And on the other side of the slide, I just want to point out to you that PTH, when given intermittently for the treatment of osteoporosis, has the same pulsatile increase over the same time period, which would suggest to us that maybe if there is any anabolic effect from exercise, that acute burst of PTH may actually be beneficial to the skeleton for another reason. So we'll come back to that as well. And then very recent data from Wendy's lab is they decided to really test whether resorption was the major mechanism for the drop, for the increase in PTH and the response to the drop in calcium. So when they blocked resorption by giving a bisphosphonate to older women, they blocked the rise in serum calcium that one would see with a saline infusion. So basically, they paralyzed the compensatory response to exercise, and these individuals had lower serum calcium. Not dangerously low, but low serum calcium. And I should mention, for those of you who have seen hypoparathyroid patients, we know from anecdotal data and from patients that we see that hypoparathyroid patients have a hard time with exercise. And we suspect that those individuals really cannot compensate for the drop in calcium that occurs during exercise. Okay, so that's just the clinical caveat. So let me summarize the first part of my talk. Long-term exercise, meta-analysis show minimal effects. There may be some microarchitectural changes. The type of exercise, the duration, and diet are critical covariates in considering the skeletal response. So loading the skeleton with a resistance training may indeed have some positive effects, although again, the changes are relatively small. And then these increases in bone turnover markers that we see really provide some insight into a catabolic response to an acute stimulus, which in this case is exercise. So it's an acute intense exercise actually associated with an uncoupled turnover system in which you have reduced bone formation, higher sclerostin, and increased resorption, a drop in calcium and an increase in PTH. I guess we shouldn't be surprised. I don't think our bodies want to build bone during a time when there's an acute catabolic stress. But what's remarkable is that this is very similar, but in one instance different from spaceflight. So in spaceflight, there is very high rates of bone resorption. There's reduced bone formation, but unlike acute exercise, PTH is suppressed because you got this constant drive of calcium coming out of bone. So two different scenarios, but indeed very similar responses of the skeleton. And that really just belays the fact the skeleton is so homeostatic in terms of its responses to stress. Okay, so we were interested in understanding how bone may be impacted by muscle factors. So we knew that short term, there was this drive for resorption, but we couldn't figure out what was going on between muscle and bone. So muscle inserts on bone, and loading experiments in mice have constantly shown that if you increase muscle tone, you'll increase bone mass. And so we were interested in trying to understand what those myokines were and whether they had a strong impact on bone. And if they did, why is it that we don't see a dramatic anabolic signal? So we were very interested in understanding the role of PGC1 alpha, which is upregulated in muscle, in driving the release of other myokine-like factors from muscle, and whether either locally or systemically, this increase in muscle-specific factors could impact the skeleton in a positive way. So it's really the search for the mysterious factors that might impact the skeleton, as well as fat tissue. And we were intrigued by work from Bruce Spiegelman's group, which showed that with the increase in PGC1 alpha, whether you overexpress it and get big muscles, or whether it's expressed in response to exercise, that PGC1 alpha can induce the production of FNDC5, which is a muscle but not muscle specific protein, which is cleaved during acute exercise. It's a fibronectin-like compound. It's released during acute exercise by being cleaved by an enzyme that we still don't quite know what it is, but it gets cleaved to form this other molecule called irisin, which was named by Bruce and was found to have an impact on brown adipose tissue. So there was a lot of controversy about irisin. A lot of people, because of the way the alternative promoter site for it, the ATG, was not the major driver of FNDC5. There was a lot of controversy as to whether this protein actually did exist, and then what it was doing when it was in the circulation, and what concentrations did it exist in. And really, it was Bruce's work using mass spec that ultimately showed that the concentration of irisin in the circulation is about 3 to 5 nanograms per ml. The assays for irisin are terrible, so virtually all the publications looking at clinical data are wrong because there's not a good antibody to irisin, and the Spiegelman Lab's been working on an antibody for that for a while. And we know that irisin is in the range of leptin resistant and insulin in terms of its circulating levels, about 3 nanograms per ml, and then it also goes up with with exercise. So Bruce had called us and said, look, we're interested in whether we can find a cell target for irisin. And he was having trouble with the adipocyte target because he was looking for the receptor for irisin, and he suspected that bone might be a target. So we had done some previous work for him looking at meteorin-like protein and found no impact of meteorin-like protein on the skeleton. And so he asked us to join his group. So we knew that irisin had an impact on white adipose tissue to increase thermogenesis. And it made sense that one of the mechanisms that exercise might work through for fat mass reduction is by beiging of subcutaneous fat tissue. And more recently, Shingo Kawamura, who has rejoined Beth Israel now, after coming back from UCSF, has shown that the integrins bind irisin, and one of the cofactors for that binding is CD81. And we'll come back to that in a minute. So we were charged with trying to figure out for Bruce whether bone was a target for irisin, and if it was, what was the receptor for it? So again, reminding you that the most obvious thought was that irisin would target the osteoblast to stimulate new bone formation, and that it would work through, potentially through integrin-like receptors. But we also considered whether they could be on osteocytes and also on the osteoclast. Well, we sort of got scooped. We had a call from this group that was ready to publish a paper in PNAS that said that irisin had an anabolic effect on bone. And they offered us to be co-authors, and we talked about it with Bruce, and he said, no, let's just do our thing. We're going to take a genetic approach. So they published this work on irisin and looked at recombinant irisin injections given once a week in very low dose to mice, and showed there was a increase in cortical bone mass. If you can see the white lines on the tibia and fibula suggesting increased cortical bone mass, and included strengthening of the skeleton at those sites using bone breaking techniques. Interestingly enough, though, the improvement in cortical bone was not accompanied by any improvement in trabecular bone. So this was purely a cortical phenotype. Now that fits very nicely with the idea that if myokines are being released from muscle, they could diffuse locally to, because they're attached to the tendons, they could, and ligaments, they could actually diffuse to the cortical skeleton without getting inside the bone and have an impact. The same group then went on to show that they could use irisin to prevent the bone loss of immobilization. So as I told you before, immobilization leads to very high rates of bone resorption and suppression of bone formation. And their hypothesis was that you could block that unloading by giving a molecular substance produced by muscle that would prevent that without loading the muscle. However, and again, in this paper, it was certainly suggestive that there was an effect, but in fact, some of the changes in bone were either marginally significant or not significant at all. So there was always some question whether or not this was, the real phenomena, plus what was the irisin made of, and was it purified from bacteria, and if so, was there LPS in there? So a lot of questions, although it did get published. But interestingly enough, one of the things that they did show was that even though this was thought to be an anabolic factor, this once a week treatment for 4 weeks, there was an increase in the number of osteoclasts. And that sort of intrigued us a bit. So we decided to take a genetic approach. Bruce charged us with, so what's irisin doing to the skeleton? So we got a muscle-specific FMDC5 transgenic from Eric Olson at UT Southwestern. And we began to look at the skeletal response to increases in FMDC5. And much to our surprise, what we found was that using the muscle-specific promoter, bone mass was actually reduced in response to forced expression of FMDC5. These are vertebrae, and you can see the von Casa staining of the trabeculi are markedly reduced. And in work with Mary Buckstein's lab at Beth Israel, the white bars represent the forced expression of FMDC5, and bone volume fraction is significantly lower at both 2 months of age and 4.5 months of age. It normalizes out at 13 months, and we can come back to that at the end, because that may have some significance in terms of how the body accommodates to long-term overexpression of irisin. But the bottom line was exactly the opposite of what we expected, and somewhat of a catabolic signal. So we were interested in understanding that, and we did bone histomorphometry and confirmed this very marked reduction in the bone volume fraction, trabecular thickness, less trabeculi, and more spacing. Just the opposite of what that other group had shown. And what we found was that when we looked at the specifics by histomorphometry, bone formation was suppressed, and there was a tendency for more bone resorption, so, and more osteoclasts. So we were really confused. Why would overexpression of this fibronectin-like molecule actually cause the opposite effect than what we would have predicted? That is, a catabolic response. So we decided to look at the osteocyte, and this is work from Roland Baron's lab, using backscatter electron microscopy. And these little holes represent lacunae in which osteocytes are living inside those holes. And during stresses, the osteocyte can release enzymes that digest the bone. It's called osteocytic osteolysis. And we know during estrogen deprivation, during lactation, during stresses to the system, bone resorption occurs on osteoclasts, but also occurs in the osteocyte. And so you should see more of these osteocytic lacunae. And in fact, that's what we saw at the 8-week time point. We did not see it at 13 months. And remember, at that time, bone mass was equivalent between the mutant and the control. But here you see more of these osteocytic lacunae. So we then went on to look at biochemical markers of bone formation, and what we found was that sclerostin was increased and bone formation was suppressed. And this suggested to us that, in fact, there is this catabolic response with overexpression in the mouse model. In addition, we were worried because FMDC5 forced expression demonstrated that this was leaky and that it was found in the bone marrow as well as in muscle. Okay, somebody might need to mute. We did not see any effect of in isolating mesenchymal stromal cells from these mice in response to overexpression. So bone formation was not impaired or increased in vitro in these overexpressing mice. So in the first mouse model, there was decreased bone formation, increased osteoclast number and resorption, a leaky promoter, no surprise, the MCK promoter was leaky. But in vitro, we found large numbers of osteoclasts. And that was an initial clue that this catabolic response was not just on the osteocyte, but potentially on osteoclasts. More osteoclasts, bigger osteoclasts in vitro and in vivo. So more recently, we've tried doing AAV, GFP, and AAV-irisin administration for 8 weeks in male mice. And we have looked at trabecular bone and cortical bone and shown absolutely no change in any parameter. So even with short-term chronic administration, we've been unable to demonstrate an anabolic effect. Okay, so we then turned to a knockout model. And we wanted to ask the question, in the knockout model, is there the opposite effect? Do these mice actually gain bone? And here you can see from the upper left and upper right that with the elimination, genetic elimination of FNDC5, the vertebral bone mass is significantly higher in the knockout mouse. And that was very consistent throughout all the trabecular bone. It's a huge increase in bone number and size. And when we did ovariectomy in the FNDC5 knockout mice, we expected bone loss to occur in the wild type mice, but in the in the mutant mice, they were protected from ovariectomy-induced bone loss. So there was no change in bone mass in response to ovariectomy, which is pretty remarkable since it's a huge driver of bone loss is the removal of estrogen. And remarkably, osteoclasts were unchanged in response to ovariectomy, and normally they double or triple in response to ovariectomy. And then when we looked at the osteocytes in response to ovariectomy, we were able to show that they were protected against this osteocytic osteolysis, that the lacunar area was markedly reduced. And this effect was quite dramatic, actually, suggesting that one, irisin probably targets the osteocyte, and two, that's one of the mechanisms by which bone loss was prevented. So subsequent work by a talented postdoc in Linda Bonewall's lab and also in Bruce's lab showed that irisin actually prevented osteocyte-induced apoptosis and cell death, and that this effect was dose-dependent and quite significant, suggesting that indeed the osteocyte was one of the targets for irisin. In osteocyte-enriched bone or in a cell line, the MLOY4, interestingly enough, irisin recapitulates its in vivo effects of increasing sclerostin by showing the same thing in vitro. There's a marked increase in sclerostin expression in response to irisin. And it increases sclerostin in the circulation as well of mice in response to irisin. So subsequent work looking at proteomics, we were able to identify integrin alpha V beta 1 and beta 5 as being two of the most important integrins that bound irisin. And this was published in Cell. And these data support the concept that was also reported by Shingo Kawamura that in the integrins alpha 1 beta 5 and alpha V beta 1 and alpha V beta 5 are the two primary receptors that bind irisin. So that was published in Cell, and we subsequently went on to really try to figure out more about the mechanism. So why would this happen, and what impact does this have on whole body calcium homeostasis? So we had a clue that CTX was increased in the in vivo studies. Remember the Army recruits, and also in the human studies of short-term exercise. We knew that CTX was increased, suggesting bone resorption was occurring. Some of it is clearly related to osteocytic osteolysis, but also we suspected that the osteoclast was involved. And when we had originally made the observation about FNDC5 transgenics having low bone mass, we were surprised. I remember the Saturday morning I was sitting in the lab and looking at in vitro cultures of osteoclasts. And there was a remarkable number of osteoclasts, more than controls in the transgenic, and they were big osteoclasts. And I remember telling Bruce, I said, you know, I haven't seen these big osteoclasts. So we decided to go back. So certainly the osteocyte is one target of irisin, and look at the osteoclast. So this is some work just published in eLife about a month ago. And what we did is we looked at in vitro stimulation of primary cells from black 6 mice isolated as bone marrow cells and treated with doses of irisin. And you can see in the upper right that doses between 2 and 10 are really the sweet spot for irisin, which is the physiologic level, 3 to 5 nanograms per ml. You get these big osteocytes, osteoclasts, which are considerably more than what you see in the control group. In addition to that, we looked at both intermittent and continuous administration of irisin. And we identified alpha V beta 5 as being one of the primary markers of irisin action. Goes up significantly in response to irisin, and that effect on osteoclasts is blocked by the addition of a specific irisin, a alpha V beta 5 antibody. We also looked at raw cells, which are macrophage cell line that can become osteoclasts in response to MCSF and rankle. In addition to that, we noted, and again, this goes back to the observation we made a number of years ago that the transgenics had very big osteoclasts, that there was an increase in the number of osteoclasts that, in terms of their multinucleated number, how many nuclei were present per osteoclast, in the frequency distribution you see here, that there's a marked difference in the number of large osteoclasts in response in vitro to irisin versus no treatment. And we subsequently went on to show that irisin drives bone resorption in vitro. You get to see these pits that occur in denting bone, and the major mechanism for that increase in those pits are really greater numbers of large osteoclasts. So, so it's not that it's driving more resorption, but driving more cells of the more differentiated variety. So less of a recruitment of osteoclasts and more progenitors, and more a larger number of osteoclasts. And then using RNA-seq to do an unbiased approach, what we found was that some of the important differentiation markers for osteoclast differentiation were markedly increased by irisin, as well as an increase in markers that could signal back to the osteoblast, what we call clastikines. And these are molecules such as Win5A and 10A, as well as TGF-beta, that can actually drive bone formation. And this led us to look more carefully at some of these markers of bone resorption, but also the markers that would drive bone formation. So in respect to genetic studies, what we found was forced expression of FNDC5 causes bone loss, reduced bone formation, increased sclerostin, and greater resorption. Deletion of FNDC5 results in protection against ovariectomy-induced osteocytic osteolysis, osteoclastogenesis, and bone loss. AAV administration, currently we have no evidence that it changes bone mass, and we wonder if there's some equilibration. Irisin upregulates sclerostin and rankle, which is a major driver of osteoclastogenesis in osteocytes. And that drives bone resorption both directly and indirectly. And irisin activates alpha V beta 1 and 5 integrins on osteocytes and osteoclasts. So So that's intriguing for us. It suggests that iris, at least initially, somewhat catabolic, but could signal backwards to the osteoblast to drive bone formation if it's seen in either a pulsatile manner or intermittently in some other fashion. And that's what we're currently working on now, mouse models looking at FNDC5 and irisin in particular in respect to intermittent administration as a potential mediator. So what are the lessons for us from humans? And we go back to Wendy Court's data, and what we realize is that during acute exercise, there's a drive to maintain serum calcium. And that drive to maintain serum calcium is due to a drop in the extracellular calcium probably going into muscle during exercise. And that PTH goes up during this drive, and that PTH increase then stimulates both osteoclastogenesis by inducing rankle production from the osteoblast, but also acutely driving osteocytic osteolysis. So if you want to get calcium out of bone really quickly, you can't do it by, you can do it, but it takes a while to drive bone resorption through rankle because you have to differentiate a progenitor cell. So that takes a little bit of time. So the most acute response to a drop in calcium and an increase in PTH at the bone level is osteocytic osteolysis. And we've shown fairly consistently that using backscatter and electron microscopy, then in fact osteocytic osteolysis is blunted in the absence of irisin. And in overexpressing models, there's more and larger lacunae, suggesting that that could be one of the principal mechanisms. So what is irisin doing? So we think irisin actually is an important counter-regulatory hormone that's released from muscle during acute exercise as a way to modulate the drop in serum calcium. In other words, it might work in concert with PTH to modulate that drop in calcium, or be synergistic with PTH such that you get the return of serum calcium rather acutely in response to that really rapid influx of calcium going into muscle. But it also raises a more interesting question that some of the early work that I showed you that we didn't do suggested that irisin could be anabolic. Well, it could be. I mean, one thing we know is that PTH goes up acutely with exercise, and that is a sort of similar response that one would see with intermittent administration. And two, we now have data that the osteoclast, once it's signaled by irisin, can actually stimulate osteoblastogenesis. So over a long period of time, it's conceivable that the compensatory mechanism for the catabolic effect of irisin is a coupling that occurs over time. And we suspect that the AAV infusions that we did with irisin probably represent that compensatory response in which the skeleton is re-equilibrated by an increase in resorption, but an increase in formation. So what are our challenges? So we want to know how important CD81 is in regulating osteoclast differentiation. Shingo's shown it in adipocytes. We wonder if it's important for the fusion of early macrophage progenitors to become osteoclasts. We still don't know what the enzyme is that cleaves FNDC5. We don't know the source of circulating irisin. We suspect it's muscle, but it could be heart, and it's expressed in the brain in high concentrations as well. So after a couple of years of trying, we finally have, using CRISPR-Cas9, a floxed FNDC5 mouse, and we're starting crossing with adiponectin and muscle and brain promoters as well. And then what happens to irisin concentrations with long-term exercise? We don't know because the assays aren't very good. And we hope to be able to solve that with an antibody studies that Bruce has conducted. And what are the classidokines that are activated by irisin that may work backwards to stimulate new bone formation? So this is Bruce's lab, and Chad has been the driver of the irisin story. This is our lab. It's a little different, but not quite as endowed, but certainly making some progress. So I will end there, and I'm happy to answer any questions, and looking forward to also the residents' discussion.